Hi Dents, how are you? This is Mohammed Musa from AFK Study Plan. Today we are going to continue what we started with AFK Weekly Newsletter. We usually post a question in our community once every day, and we get the answer by the end of the day. And by the end of the week, we do a condensed video to accumulate everything in one video, one presentation for your reference to keep it to watch the questions and the answers. With that being said, let's just start it now. So our first question from pathology. During a cytological smear, a fungal hyphae was observed. You prescribed nystatin for 2 weeks. During the follow-up appointment, the patient returns with edematous red mucosa. Further management is 2. So this patient is mixed between clinical scenario and pathology knowledge. He's saying like you confirm the diagnosis with cytological smear, and you give the correct medication, which is nystatin, for 2 weeks. So he's telling you the appropriate management has been done, but it's still not working for this patient. He coming back with edematous red mucosa. So let's read the answers here. So give nystatin for another 15 days? No, make no sense because your patient has just finished 2 weeks of nystatin, so we cannot give another 2 weeks. Biopsy, let's think about this one. Observe, you cannot observe for something is just escalating. Your patient is follow up, doing his medication and escalating. Run laboratory tests, which is partially correct. You need to do some tests, but when you think about biopsy, biopsy is the accurate answer here. And here is a trick for you. When you see answer which is general, option which is general, and there is another option which is specific, so you pick the specific one because like laboratory test is a general statement which is partially correct, but when you think about biopsy, biopsy is what we really need here. Why we need biopsy here? Because like you did your homework before, you confirm it is hyphae, which is fungal, you give the correct medication, correct duration, still the condition is even escalating, is not healing. So you should do a biopsy to confirm what's happening here. And here is a reference from PubMed, like this procedure about a biopsy makes it possible to confirm or deny diagnosis, as well as to determine the nature and characteristics of the lesion and to establish a final diagnosis. Oral biopsy is a simple procedure which is in most cases can easily be performed by odontologist. Like he's saying, like you might send him to pathology specialist, but most commonly you can do it as a general dentist in your office. And I think that's it for this question. And there's here more evidence. Biopsy is done for suspicious lesions present in the area, any tissue removed for any reason, and positive exfoliative cytology. So he's speaking about like even if you do the cytology exfoliative, which is a cytological smear, but still not working. Like you cannot tell your patient just go home. We need to investigate more about it. And as we said before, like a run laboratory test is partially correct, but biopsy is accurate answer here. Second question is from anatomy. During the embryological development process, failure of maxillary process to fuse with mandibular process will result in. This topic is little annoying, but like if you get the concept, it will be easy for you to reach the answer. I would like most of the dentists reading this question, his mouse or his pen is jumping to this cleft palate, but you need to read carefully here. He's speaking about the maxillary and mandibular process. So he's speaking about this and this. So if a failure happen here, it will lead to commercial lipids. And then there is other option here. Let me give you a beautiful diagram. We'll wrap it up for you. So medium cleft lip, which is here, is result from a failure of the medial nasal prominence to merge and form the intermaxillary segment. So the medial nasal process from right side and left side, if a failure happen here, it will lead to median cleft lip in the philtrum here. Second type of cleft is unilateral cleft lip, result from failure of maxillary prominence to merge with the medial nasal prominence on the affected side. So it's happening in the right side or left side, the medial nasal process with maxillary process when happen a failure here, it will lead to a unilateral. And as you can conclude now, bilateral result due to failure of maxillary prominence to meet and unite with medial nasal prominence on both sides. Like here is the unilateral and here is bilateral. To wrap it up, to medial nasal, medial nasal when the failure to fuse, so median cleft lip. And the cleft lip, it's unilateral or bilateral. When it's unilateral, so it's maxillary with the medial nasal. If it's bilateral, maxillary with medial nasal in the both sides. It's a little confusing if I tell you the lateral aspect of medial nasal process, so you think it's about the lateral maxillary. It sometimes is confusing, but like if you repeat it for yourself twice or three times and look at picture, because this is my humble advice for you. For pathology, you never say pathology with a picture. You don't go. I just read the text here. Um, I intend to do this text and picture. When you connect the text and the picture in your mind, it becomes super easy for you to remember. Like sometimes when you forgot this text or something is missing here, you think about the medial nasal process here and maxillary here. So, and the maxillary is here, mandibular is here. So the failure is here leading to this one, leading to this one. So it's about visualization. When you visualize it, it will be super easy to memorize and even recall it again. Second question is from anatomy. During the embryological development process, failure of maxillary process to fuse with mandibular process will result in. This topic is little annoying, but like if you get the concept, it will be easy for you to reach the answer. I would like most of the dentists reading this question, his mouse or his pen is jumping to this cleft palate, but you need to read carefully here. He's speaking about the maxillary and mandibular process. So he's speaking about this and this. So if a failure happen here, it will lead to commercial lipids. And then there is other option here. Let me give you a beautiful diagram. We'll wrap it up for you. So medium cleft lip, which is here, is result from a failure of the medial nasal prominence to merge and form the intermaxillary segment. So the medial nasal process from right side and left side, if a failure happen here, it will lead to median cleft lip in the philtrum here. Second type of cleft is unilateral cleft lip, result from failure of maxillary prominence to merge with the medial nasal prominence on the affected side. So it's happening in the right side or left side, the medial nasal process with maxillary process. When happen a failure here, it will lead to a unilateral. And as you can conclude now, bilateral result due to failure of maxillary prominence to meet and unite with medial nasal prominence on both sides. Like here is the unilateral and here is bilateral. To wrap it up, to medial nasal, when the failure to fuse, so median cleft lip. And the cleft lip, it's unilateral or bilateral. When it's unilateral, so it's maxillary with the medial nasal. If it's bilateral, maxillary with medial nasal in the both sides. It's a little confusing if I tell you the lateral aspect of medial nasal process, so you think it's about the lateral maxillary. It sometimes is confusing, but like if you repeat it for yourself twice or three times and look at picture, because this is my humble advice for you. For pathology, you never say pathology with a picture. You don't go. I just read the text here. I intend to do this text and picture. When you connect the text and the picture in your mind, it becomes super easy for you to remember. Like sometimes when you forgot this text or something is missing here, you think about the medial nasal process here and maxillary here. So, and the maxillary is here, mandibular is here. So the failure is here leading to this one, leading to this one. So it's about visualization. When you visualize it, it will be super easy to memorize and even recall it again. I hope that was clear for you. Third question from Perio. What is the clinical attachment loss for a patient with a pocket depth of 8 mm and gingival margin lying 3 mm coronal to the cement-to-enamel junction? So this topic is extremely easy. Just you need to, again, to visualize it. So let's first, before we reach the number, let's first know what's the meaning of each terminology. So gingival margin is this part, and cement-to-enamel junction is the part which is a connection between the crown and root, and the depth of the pocket is this port. So this is your probe you are going to use. So when your probe is going from the gingival margin to the depth of the pocket, this is the probing depth. So this one is the probing depth. When the gingival margin is at cement to enamel junction, so the probing depth will be clinical attachment loss. It's the same number because clinical attachment loss is from cement to enamel junction to the depth of the pocket. So here comes confusion part. So you should correlate between the gingival margin and cement to enamel junction. Correlation between these two landmarks is important as clinical attachment loss is from cement to enamel junction to depth of the pocket and probing depth is from the gingival margin to depth of the pocket. So let's think about the other two scenarios. You see here the gingival margin is apical to cement to enamel junction. So as you conclude now, the attachment loss will be number from here to the depth of the pocket, but the probing depth will be less. So the probing depth will be less, but the clinical attachment loss will be more. Why? Because you have positive value of gingival recession. And vice versa on the other side, if the gingival margin is coronal to the cement to enamel junction, so you will be having a lot of probing depth. It will be long probing depth, but minimum clinical attachment loss as the gingival recession here will be negative. So let's explain it more here. So the pocket depth is clinical attachment loss in this situation because like some dentists confuse when is this information is true. This information is true providing the gingival margin is at cement to enamel junction. When the gingival margin and cement to enamel junction is not in the same location, so you are going to a different scenario. The first scenario, as we said, when the gingival margin is apical to cement to enamel junction with a positive value of recession, so clinical attachment loss will be both recession, this part, and pocket depth at this part. And that third scenario, when the other way, when the gingival going up due to phenytoin, due to some ortho treatment, due to other medication or condition, so the pocket depth will be minus gingival recession, and then you can reach that clinical attachment loss. So it's easy when you visualize it. It's easy when you go to the number. So here we have scenario A, like the gingival margin is apic coronal to the cement to enamel junction. So the probing depth is 5, recession is 3, so the total will be 5 plus 3. And as you go here, you can read and you can reach the correct answer. Sorry, C here is a probing depth is 3 and recession is minus 3 as the gingiva is going up. So the total will be 0. Clinical attachment loss will be 0. And for B scenario, this one, the gingival margin and pocket of the depth. So probing pocket is 4, and recession is 0 as the gingival margin is at cement to enamel junction. So 4 plus 0 equal 4. And here when you have a recession by positive value is scenario A, probing depth will be 5 and recession will be 3. So you are going to make a plus for both to give you the answer will be 8. I hope this is clear. If it's a little confusing, maybe you can watch the video again to get the idea. And again, please try to get the number with the picture. Number with the picture. When you correlate them together in your mind, it will be easy. So here the question is saying the gingival margin is 3 millimeter coronal to cement to enamel junction. So you are going, and the probing depth is 8. So it's 8 minus 3, which lead to 5. I hope this was clear for you. Pathology. An 18-month-old child presented with vesicles on the buccal mucosa, fever, and lymphadenopathy. Which of the following is the primary management? So before you read the option, you should think about it, which condition you speak about here. So it's very important keyword here, 18 month. 18 month will let you think about some specific condition. And then let's go more. Vesicles on the buccal mucosa, fever, lymphadenopathy. And this is aiming directly to primary herpetic gingivostomatitis. So you know the diagnosis here is primary herpetic gingivostomatitis, and then he's asking about the management, antiviral, antibiotic, antifungal, or antibiotic and analgesics. So let's speak about this condition first and then conclude the answer. PHS, primary herpetic gingivostomatitis, is a viral infection caused by herpes simplex type 1, and I would like to memorize which condition is caused by which virus because this is important. It's a self-limiting disease, and this is critical here because self-limiting means you don't need to intervene. Characterized by presence of systematic prodrome, fever, malaise, and headache. Clinical picture will be multiple small painful ulcers all over the mouth with gingival inflammation and increased salivation. This poor kid have this condition, but thanks God it's self-limiting. If you do nothing for your patient, it will go away. And this condition sometimes is happening as extraoral lesion, perioral mainly, can be found. Ulcer here without scar, it will be in the labial outside of the face. Ulcer are considered secondary infective ulcer, so it's a vesicle, the rupture leading to ulcer. Secondary as it's preceded by vesicles that erupt forming ulcer. After healing, the virus remain latent. Reactivation of the virus manifests as recurrent herpes simplex and recurrent intraoral herpes. So the poor child, when he go this a self-limited condition, when he grow old, this virus herpes simplex type 1 become latent in his nerves, and then when he has some stress, when he going through exam, when he's studying for AFK, when he has some condition leading to reduction in his immunity level, he will have this condition. It will be vesicles that would rupture, leading to an ulcer. That's why we're saying it's a secondary one, and it healed without a scar. It might happen intraorally, but it's not very common. When it happens intraorally, it will be unilateral, most commonly, sometimes bilateral, but strictly will be happening in the attached mucosa. And how to differentiate between this one and aphthous ulcer is super easy. If it's preceded by vesicles, so it's recurrent labialis. And second, which is not super accurate, but like you can aim for this one, if the question is saying it's in attached gingiva or keratinized gingiva or non-keratinized gingiva, because recurrent herpes is most commonly happening in attached gingiva, which is keratinized gingiva, while the other one, aphthous, is happening in non-keratinized gingiva. And last thing to differentiate between, which I don't like because it might happen in both, which is the aphthous ulcer will have a red halo, but sometimes you can see this one ulcer having a red halo. So the location is important, and the most critical one would be the clinical presentation. If you see vesicles before, it's herpes. No vesicles, it will be aphthous ulcer. For this question, so whatever you are going to do as a self-limiting, you give him antibiotic and analgesic. Sometimes some dentists will think about antibiotic or antiviral. This child is too young to do this for him. And primary gingivostomatitis, the management, as we said, is self-limiting, just supportive. You are going to support this child because he has less salivation, he has fever, lymphadenopathy, just supportive till the infection is done for him. Last question for today from pharma. Asthmatic patient using corticosteroids inhaler may develop candida on the dorsal surface of the tongue because of. So again, he's giving here a scenario saying the patient asthmatic is using steroids inhaler and he's telling you he has candida infection on his tongue. Why is this happening? Systemic antibacterial action? No, because like question saying inhaler steroids. Local destruction of normal oral flora, which is like correct, partially correct. Let's see other option. Prolonged local vasoconstriction. Mean nothing here. Steroids will never do vasoconstriction as a topical application. Cross-reaction antigen in the tongue. You think about it. Or local immunosuppression. So here the question saying he's using steroid, as we know steroid is used for this patient to control his asthmatic attack and make the frequency less and severity less. But think about it for your patient when he's using this inhaler. Some of the inhaler steroids is staying in his mouth, some staying in his throat and his tongue. So when this is stay in his tongue, corticosteroids is act as local immunocompressive. When the local immunocompression happening in this area, and here go the Candida albicans. Candida albicans is opportunistic infection when the immunity is lowered, so it has a chance for her and to grow more and more. And when it grow more and more, it will lead to candidal infection. So here the picture you will see this looks like this one. You will see a patient with candidal infection in his tongue, and when you speak about him, you will see he has some history of prolonged uses of antibiotic or some steroid inhaler. So local immunosuppressive, as when the patient is using his steroid inhaler, some of the solution goes to his throat and some stays over the tongue. working to suppress the immune system, giving a chance to Candida albicans, as we said, is opportunistic infection, to have more chance to grow, leading to the fungal infection. What you are going to do is to ask your patient to drink some water after using the inhaler and give him short-term topical antifungal, because you cannot let your patient to just go home with this infection, but you should do both. Give him the medication, which will be nystatin for 7 to 14 days, and you're asking him gently to use cup of water after using his inhaler, or just to swallow his mouth, rinse his mouth with some water, because this is harmful for his tongue and throat. So the answer here will be local immunocompression by the steroid staying in his tongue and his throat. Okay, that coming to our end for today lecture. It was condensed and simple. I hope you can get some topics here and some answers, and you can refine your study. And that's it for today. Thank you very much, and see you next week.